Looks perfect.
Am I leading off?
No, I can start a little bit with the introduction, Dr. Lafayette. So good
Okay.
morning, good morning or good afternoon or evening, everybody. Thank you for joining us. Today we have a special seminar because it is May is the IgA Nephropathy month, and May 14th was the IgA Nephropathy Awareness Day. So we have a special seminar. We'll start with Dr. Lafayette, who would be giving um, presentation on treatment approaches to IgA nephropathy in 2025. Then will be followed by a presentation from Bonnie Schneider. She is the co-founder of the IG and the executive director of the IgA Nephropathy Foundation, as well as Stuart Miller, who's the director of strategic relationships in IgA Nephropathy Foundation as well. So we're very pleased to have them be here today and tell us a little bit about IgA Nephropathy Foundation. We also have a patient ambassador, Katie Strange. So thank you, Katie, for being here and sharing your kind of story with us about your with IgA nephropathy. And then we have Dr. Norouzi here as well. After the presentations, we'll open up the panel for discussions. So without taking much time, we'll have Dr. Lafayette start with the presentation.
Well, again, good morning to everybody. I'm very excited to be here to join GlomCon, to join colleagues at the IgA Nephropathy Foundation, to really talk about this revolution in IgA nephropathy in terms of having a tremendously expanded treatment algorithm for patients and opportunities for patients. Of course, it all starts with getting them diagnosed and to a doctor who can recognize this disease so that their options can be explored. Again, we've known about IgA nephropathy now for almost 60 years. And we know that it can have very dread consequences leading to kidney failure, leading to the need for transplant. But it's very, very variable. And we have to really understand that variability because I know patients are on the line here. I've met many, many patients through my 3 decades as a clinician. And again, each patient is an individual. So we need to individualize their stories, understand and appreciate their individual stories, and then individualize care to them. Because again, many patients can do completely well on their own over decades with no symptoms, no signs, but others can progress rapidly and really can suffer consequences of kidney damage and kidney loss. Again, over this last 60 years, we've learned a lot about what IgA nephropathy really is. And these days, we think it comes together through a polygenic risk, where numerous factors that are immune in nature, intestinal permeability in nature, related to cytokines and complement activation, are all poised to react. And if you have a stress in your mucosal system, most likely in your GI tract, but maybe in your tonsils or your oral respiratory tract, you can respond in a way where your B cells are activated. You make more galactose deficient IgA in your mucosal surface than usual. That's sustained in your blood. And then your immune system can react to that, making more anti-galactose deficient IgA antibodies. And that results in circulating immune complexes, which the kidney can then filter or can specifically bind to kidney cells in the mesangium, leading to inflammation, which then leads to the ability for there to be blood in the urine, protein in the urine, ongoing inflammation, which can lead to scar and replacement of kidney with scar, which eventually can replace kidney function with dysfunction and eventually failure. So this is what we've learned. It's the pathophysiology. And in different patients, it affects them in different fashion. Therefore, as I alluded to before, you can have patients who really are low risk, whose biopsy shows very mild features, who for the time being have normal kidney function or GFR, normal blood pressure, urine protein excretion that's near normal at less than 0.5 gram a day. And in series in the United States, in Europe, and more numerously in China and Japan, people like that can do extremely well for decades and decades. However, when the biopsy shows more activity, more chronic damage, when the proteinuria is higher, when there's reduced kidney function or high blood pressure, that marks a slightly higher risk, which goes even higher if the proteinuria is extreme, more than 2 to 3 grams per day, if the kidney function is actually falling um, every quarter by quarter, every few months, and again with more severe biopsy findings. And for very few patients, they can even have rapidly progressive glomerular nephritis with usual severe biopsy findings, usually presenting with high blood pressure, high protein, but this is defined by losing half your kidney function within 3 months. So again, very variable disease, very variable disease presentations, and it really requires us to individualize our care and identify our patients for who they are. Again, just 4 years ago, our international approach to this disease was such that, well, yes, we do for them what we do for every kidney disease, get them to exercise, have their weight good, reduce salt, not eat too much protein, look for a normal blood pressure. And if the blood pressure is good, but they have proteinuria, let's maximize drugs that can reduce proteinuria, which all we really have were renin-angiotensin system inhibitors. And if that didn't work and they were still at risk with more than a gram a day of protein, we said we really have to learn more. And brilliantly, I think KDIGO focused on clinical trials because the other options beyond conservative care, really for those patients thought to still have a salvageable kidney with kidney function more than 30 mils per minute or more than 30% of normal, were to give systemic immunosuppression. And we had had a checkered past with systemic immunosuppression. It was different country by country. Results would vary, and always there was significant toxicity. If the kidney function was already low, all we did is watch and wait and get ready for the patients to come to transplant or dialysis. Again, because systemic immunosuppression can hit hard, there were certain populations that I'm enumerating on this slide that really were terrible candidates for systemic steroids, those who are overweight, those who had latent infections, those who are diabetic, those who are less likely to work with low kidney function. So really corticosteroids were limited, and even more limited because study by study, sometimes populations of patients just did not respond historically. And in the largest European trial, while steroids could reduce proteinuria in that upper panel, leading to a full clinical remission, when we looked at hard endpoints of kidney function at first 3 years and then even at 10 years, systemic steroids or immunosuppression did not preserve kidney function in that population. And it did lead to a substantial increase in side effects, including serious infection and more typical steroid side effects. And here's that very long-term outcome showing no difference with systemic immunosuppression in a European, mostly Caucasian population. In the testing trial, an effort to treat 1,000 patients to try to see if corticosteroids were effective in an Asian population, the study was stopped early because there was initial sign of toxicity and harm. And so the monitoring board stopped the study due to too many life-threatening and actually fatal infections. The testing group did reorganize and go forward with a lower dose approach, but at a dose that still causes side effects. And they did show in a predominantly Chinese, almost entirely Asian population that you could reduce proteinuria and reduce hard endpoints by about half, but at the expense of a substantial number of side effects and still a greatly increased number of serious adverse events. So with that background, we have variable patients. We have patients who are going to do poorly just with supportive care. Systemic immunosuppression can hit them hard, can be ineffective in many, and even those it's effective in may have too many adverse events. And furthermore, those interventions may be temporary. You may be able to reduce hard outcomes such as presenting to dialysis needing transplant, but if you follow after systemic immunosuppression for 3-4 years, most patients are back to where they started from. And so therefore, they're looking at recurrent treatment with these agents that can cause lots of side effects and put their life at jeopardy. So again, we needed to do better. We needed to re-examine the pathogenesis of the disease and say, can we go very, very early to this mucosal hyperactivity, to the creation of these antibodies or the autoantibodies? Could we reduce the inflammation that's in the kidney from cytokines or complement activation? And can we actually have more well-tolerated therapies that work across a larger population? And the answer is resoundingly yes, we can. So in 2025, jumps forward in those 4 years from the previous guidelines, where we now can think of things as non-immunosuppressive therapies aimed at downstream events that may be common across chronic kidney disease and get better proteinuria reduction, which is a major predictor of better kidney outcomes. And we've tested dual endothelin type A and angiotensin 2 receptor blocker agents that work. We've tested endothelin type A receptor antagonists by itself that work. We've looked at sodium glucose transport inhibitors, and in more advanced cases, they can reduce proteinuria and slow progression. We're now looking at aldosterone blockade and GLP-1 agonist drugs, which work in diabetic nephropathy, and hope that they'll work in IgA nephropathy as well. And then we turned our attention to the disease itself and said, can we modulate this immune response by targeting corticosteroids, not systemically to have all of their effects, but to the Peyer's patches in the intestine, reducing that initial hit and reducing the production of antibodies in the mucosal system? Can we use hydroxychloroquine, another agent that might work upstream? More work to come on that. Can we go relatively downstream to complement? And then can we go to the B cells themselves that have to make the antibodies and limit their effectiveness? There are other also immunosuppressives that may be better tolerated, like Acthar gel in small trials suggested some benefit, but needed to be better studied. So again, over these last 4 years, really a track record of huge success, starting with DAPA CKD study. This was a randomized controlled trial of an SGLT2 inhibitor. And then there was a huge subset of patients with IgA nephropathy, 270 patients. But these are older than our typical study patients, had more advanced kidney dysfunction, substantial proteinuria, substantial other comorbidities. So at this advanced stage, though, SGLT2 inhibitors could still reduce hard outcomes. So treatment led to more than a 50% reduction in doubling of creatinine or the need for dialysis in just 2 years follow-up. The study was stopped early, and this is very strong evidence for this agent helping. However, even in the dapagliflozin group, in the blue bars, you can see more and more patients month after month are still developing hard endpoints. So it slows and doesn't stop progression of kidney disease. And the EMPA kidney study likewise had an IgA nephropathy population, not as fully presented, but also showed a roughly halving of hard endpoints within 3 years. So again, we have SGLT2 inhibitors for IgA nephropathy as we do in other kidney diseases. The endothelin receptor antagonists, as I mentioned, lots of good rationale for why they can help kidney patients. They are stabilizing to the vasculature, reduce blood pressure, reduce glomerular hyperfiltration, but they also have specific kidney cell effects in the podocyte and the renal tubular cells in that mesangium that captures these autoantibodies and on inflammatory cells directly, suggesting they could be beneficial. And indeed, a trial of sparsentan early on had demonstrated efficacy in focal sclerosis. And then the PROTECT trial in IgA nephropathy demonstrated a substantial ability to reduce proteinuria by roughly half and to reduce GFR progression by about 1 to 1.1 mil per minute per year, which again, over years of treatment, will lead to significant protection against progression. But again, do note that patients treated with sparsentan still have progression of their kidney disease, just slower than otherwise optimal therapy. Again, atrasentan as a standalone endothelin receptor blocker was also tested, and we have the initial results of atrasentan leading to a clinically significant reduction of proteinuria without increased adverse events. So we also now have atrasentan as an approved intervention for patients in IgA nephropathy in the United States. When we look at immunosuppressive or targeted therapy, again, I already mentioned that corticosteroids have too many cons in terms of systemic dosing, and therefore it was very attractive to look forward. I'm sorry, my slides, I think, jumped ahead. And Nefecon as an agent which targets the gut and uses budesonide, an agent which is eaten up by the liver through what's called a first pass metabolism, such that the systemic exposure is much lower than gut exposure, was demonstrated highly effective at reducing proteinuria with 9 months of treatment. You can see at 12 months of observation, there's a 51% reduction of proteinuria, which is sustained but ebbs somewhat through 18 months off drug, 15 months off drug. So patients do benefit with the antiproteinuric effect. They still have that antiproteinuric effect at 24 months after receiving only 9 months of drug, but the effect is fading. The GFR effect looks a little bit more potent in terms of a bigger separation than what we saw from sparsentan, but maybe the baseline therapy of these patients wasn't as strong. But still, there's a very substantial GFR saving effect of this agent, making it also, it was the first approved drug in the United States for IgA nephropathy. And even at 2 years, you can see a substantial saving of kidney function loss with Nefecon. So that was a 5 mil per minute loss that was saved by the use on average in this study. Furthermore, we can look at the inflammation in the kidney. There's a lot of evidence that this results from activation of the complement system, a inflammatory system that we all have to react to foreign invasion, infection, even to cancer. And again, within the pathophysiology of IgA nephropathy, there's good reason to think that this works downstream. We now know that the immune complexes are shepherded by complement as well. So blocking complement would seem to be a good idea. We've developed multiple ways to block complement thanks to industry and academic partnerships. So we could block multiple stages of complement activation. And we already have evidence that blocking the alternate pathway of complement activation using an oral factor B inhibitor can lead to a clinically relevant reduction of proteinuria. Here you can see a nearly 40% reduction of proteinuria in the iptacopan phase 3 study, also leading to its approval by the FDA as another therapy that we can use. Again, we're on the dawn of even further therapies, such as blocking B cells, the cells that are the factory of these antibodies. And we have numerous agents that can block B cell development and block the activation of B cells to make the IgA and IgG antibodies that we typically see in the kidney in IgA nephropathy. And again, early evidence is that these agents blocking cell factors that stimulate B cells, such as APRIL, can be highly effective at reducing systemic IgA, reducing proteinuria, and stopping progression of kidney disease. In this case, in 1 year, the GFR did not progress at all compared to a healthy population and had a significant protective effect over the control group at 12 months. with an APRIL blocker. And with an APRIL and BAFF blocker, similarly, we saw a reduction of galactose-deficient IgA1, reduction of hematuria, reduction in proteinuria. But this followed patients not only to the 72 weeks here seen in your screen, but all the way to 96 weeks, and showed an absolute stability of kidney function. So we'll have to watch this space carefully as these B-cell therapies complete phase 3. Again, there's multiple types of these B-cell modulators blocking BAFF or APRIL. And we could also block a substance called anti-CD38 to go directly to the plasma cells. And the data is looking very, very exciting, such that now we have new paradigms where new drugs are available, that we want to diagnose IgA nephropathy early, make sure we understand what's going on clinically. We want to risk assess our patients, and regardless of risk, we want to optimize that risk with lifestyle modifications, excellent blood pressure control, and use of RAS inhibitors. If they do well with that, that's fantastic if they're low risk. But if they maintain a high risk status, we could still think about developing new drugs. But we now have options where we can treat these patients, particularly if they appear salvageable with GFRs more than 25 to 30 mils per minute, and think about targeted steroids, or think about now utilizing complement inhibitors, or giving them conservative therapy with sparsentan, atrasentan, SGLT2 inhibitors, and then if needed, on top of angiotensin 2 receptor blockers, which isn't needed when you have sparsentan. So again, the idea would be to look at the patient, individualize them, realize they may already have chronic kidney disease that needs a maximal response of conservative care, blood pressure control, and all the agents needed to get them to low risk, to low proteinuria. And remember, they have underlying IgA nephropathy. And now look at that immunological dimension to use all the treatments we have there to stop both sides, with the goal of absolutely protecting their kidney, stopping them from losing more nephrons, and stabilizing kidney function to best of our degree. So again, there's huge competition now for treatment, at least in the United States. And when we want to stop nephron loss, we want to stop glomerular inflammation, we want to reduce that underlying production of galactose-deficient IgA1, and we want to stop those profibrotic signals in the kidney. And we now have a laundry list of medications we can use to get to those goals. Again, the present KDIGO guidelines are such that they see the success that has been attained through collaboration of patients, physicians, industry, and the government allowing these studies to occur, that we're now getting greedy. We want to treat even lower risk patients who have proteinuria less than 0.5, because we've learned some of them are not low risk, especially if they've got kidney damage and lower GFR. The KDIGO guidelines said we should really think about addressing those generic CKD issues together with the underlying IgAN specific pathways, including inflammation. And there's a little less emphasis on clinical trials and more emphasis on getting to active therapy right away for patients, particularly at risk. And therefore, I agree, patients at risk must be identified and treated. Conservative therapy helps. Maximal RAS inhibitor helps. In some cases, it is enough. If the proteinuria is very low grade, patient's kidney function is absolutely stable, you may not need further therapy. If not, we have other agents like SGLT2 inhibitors, endothelin blockers. Potentially we'll have mineralocorticoid receptor antagonists, GLP-1 agonists. So we can keep adding therapy if we don't see the proteinuria get low enough. But beyond lowering the proteinuria, there's attention to the kidney itself. Again, in some populations, systemic steroids may be beneficial, but adverse events are, in my opinion, too numerous. Tarpeo as a targeted budesonide may be better tolerated. We're going to see the GFR data on iptacopan and other complement blockers. are on their way, like ravulizumab looked very potent in its phase 2 studies. Again, we're very much waiting for these B cell antagonists to come forward because they may even be better at preserving kidney function. But the real thing is we must identify patients early when they have salvageable kidneys and can protect more of their kidney function. We need to make good choices to treat them. And then once we treat, we have to constantly reevaluate that the treatment's working, that it's well tolerated. If not, we need to readjust and get to our goal of preserving these kidneys, keeping patients healthy, active with their families, and leading their lives. So I will stop there and be happy to take questions.
Thank you, Dr. Lafayette. That was a very good summary of the new things happening in the IgA nephropathy world. We'll just do questions, all the questions at the end for the panel. So we'll just have Bonnie Schneider now kind of give an overview of IgA Nephropathy Foundation. Bonnie.
Thank you for having us. Super honored to be here. Just listening to their presentation, I have goosebumps because 21 years ago, I dreamt of this happening. So I'm Bonnie Schneider, co-founder along with my husband of the IgA Nephropathy Foundation. In 2004, our 13-year-old boy, we sent to school after having an upper respiratory infection. And he came home and said, "Mom, went to the bathroom and my pee looked like Coca-Cola." So immediately, of course, any mother hearing that out of their son, I was petrified. So fast track, a week later, he was diagnosed with IgA nephropathy. We spent about a year and a half him being very nephrotic and he missed like 47 days of school. We couldn't get him stable. He was on enormous amounts of steroids. He was so swollen. And a 13-year-old boy on steroids is really quite a handful. But during this time, we realized I wanted to find a mom or a dad or somebody that could, kind of walk us through the process of what was happening to our son. And we couldn't find anybody. And I'm like, where are these 100,000 people supposedly that have this if I can't find anybody? And then I looked for a foundation to join, somebody that could just tell me what was happening to our son. And we couldn't, there was nothing out there. So we decided 21 years ago that we were going to start the IgA Nephropathy Foundation just to give that hope to other people and the feeling that they are not alone. And now we're exploding with new patients every day and helping them get through the process. And one of the things that motivated my husband and I way back when we started was we need better drugs on the market. Like watching your child on steroids or anybody on steroids is not fun. And ACE and ARBs. And it was really like such a lack of control. And during this time, quickly, our daughter was diagnosed with Hodgkin's lymphoma. But this was 6 months after Eddie. But as scary as cancer is, I felt like, the doctor said, we're going to put her on AVVD for 6 months, and then we're going to put her on 6 weeks of radiation. I felt like when I walked out of there that somebody was driving that ship that I could rely on. I didn't like making decisions about the future of Eddie being 13 years old, 14 years old, 15 years old. And this is something that we prayed for. We prayed for these drugs on the market like every single day of my life, like, oh, please, let's get this doing. So I feel the same way as Dr. Lafayette. Like this is really, really an incredible time to have IgA nephropathy. And I back up on, we have to catch patients earlier in their diagnosis, which us at the foundation, we are working really, really hard on, and that earlier diagnosis prior to the nephrologist. So much more to come on that, but I think everyone here on that's listening in that treats IgA nephropathy patients, it makes their journey so much better if they have that reinforcement from you saying that, we're going to get you there, we're going to give you that support. One last thing, the mental well-being of IgA nephropathy patients far surprises everything. Flank pain, dizziness, all of it, anxiety, stress, all of that is such a huge component of having IgA nephropathy. Am I going to be able to keep my job? Am I going to need a transplant? How long am I going to live? Should I start a family? It weighs so heavy on all of our patients. So also try to keep that in mind when we're talking to patients about that. Be totally grateful for that kind of support. And Stuart will give you a snapshot of everything that we offer at the IgA Nephropathy Foundation, help our patients navigate their disease process.
Thank you, Bonnie. That was a great summary. I didn't know about how it was started, so that was amazing to know. And thank you for all the work that you do for patients and bringing them together. So, Stuart, do you want to just give us an overview now of the foundation and what all is there? And I know you had
Sure,
shared your
yeah,
slide.
absolutely. Let me share my screen for a
Yeah.
sec. Okay, you can see my screen, Tripti.
Yes, we definitely
Yes.
can see a screen. Yeah.
So the foundation offers many resources for patients and their families. Our first and one of our biggest is a mobile app called IgAN Plus, which is a tool designed to specifically for patients living with IgA nephropathy. It's user-friendly, and it's a platform for patients to manage their health and to connect with other support and other people who have IgA. We also realize that living with a rare disease can be very mentally challenging for our patients. So we provide some tools to help our patients deal with those challenges. One is a program called Calm, which is a premium membership to an app, which will help patients sleep better and be more relaxed and meditate. Talkspace, which offers our patients 2 virtual therapy sessions per month, and also unlimited texting and messaging with a virtual therapist. We offer a monthly support call for patients and for care partners. It's a great opportunity for patients and their care partners to meet other patients going through the same experience they're going through and share their experiences. Mental wellness support and also nutrition and recipes. We have our own cookbook. We offer mental wellness, mindful meditations, mental movements, and several podcasts to help patients deal with their living with IgA nephropathy. We offer patient assistance through the foundation, and also we are partners with HealthWell and the Assistance Fund, which also offer financial assistance to our patients. IgAN Hope is a patient registry that we're just getting ready to start, and it'll help patients improve their care and also help improve research on IgA. IgAN Cares is a program we created to help patients connect with nephrologists to understand what it's like to have IgA nephropathy, and we encourage anybody who's interested to join, and you can click on the link. And then Spark, which is our annual patient conference this year in Chicago, Illinois. We'll have 375 patients and their families get together to be educated, meet other patients and network with patients, and just have some fun. If you're interested in learning more information, you can visit us at www.IgAN.org.
Thank you, Stuart, for all the things you do and sharing with us so that we know and we can help our patients kind of get to those resources. Katie, I think if you are on, I think if you're probably going to talk about the opportunities and challenges from a patient perspective.
Yeah, thank you so much for having me. I was one of the lucky ones. I found the IgAN Foundation almost immediately when I was diagnosed. And it was a journey just to get my diagnosis of about 16 months of just unexplained, unconnected symptoms. I had rashes. I had just kind of some crazy lab work. I started having issues with my heart, having issues with my breathing, and just all of these things. I saw a dermatologist and a rheumatologist and a cardiologist and a pulmonologist but never a nephrologist. I don't think anybody really ever thought my kidneys were to blame here. And looking back, I wish I would have pushed harder for that. I wish a doctor Another doctor would have pushed harder for that. My GFR had been in the hundreds, and by the time I was diagnosed, I was down to 74 over the span of that 16 months. And it was a really tough time to hear what's causing it is one thing, and it gives you a sense of power that you know what you're fighting at that point. And then you read that statistic that there are not many people like you out there. My primary care physician had never heard of it. And it just was, it can lead to a dark time. I have to echo what Bonnie said about the mental piece and the mental component of hearing that you have something that is life altering. And it is very much, am I going to die? How much longer do I have? And then you fall down the rabbit hole of, Dr. Google. But I'm grateful because all of that Googling led me to the foundation. And I found a place where I could connect. I found a place where I had support, and really a place that allowed me to kind of embrace this journey that I'm on. The foundation has supported me, not just as a patient, but given me opportunities to advocate for people who may not have been able to question as much as I did and push as hard to find the reason why I had these symptoms. They have allowed me opportunities to go to Capitol Hill in Washington, D.C. and advocate for new legislation to support kidney patients. I have been able to be a part of our peer support calls, and I will help start moderating those actually starting tomorrow. I've been able to meet with different nephrologists and talk about my journey and how can we get to patients sooner, and how can we ease the burden of them having to advocate so much for themselves. Getting the knowledge in the hands of the nephrologist so that the patients can go into their doctor and have that knowledge for them. The foundation has been life changing. And I'm excited to see the growth. Just since I have been around for my short time, the number of new patients and the recognition of IgA nephropathy around the country and around the world is just incredible to see, and knowing that we're making a difference so that patients don't have to go through what so many of us went through.
Thank you, Katie, for sharing, and that is not easy to share. So really appreciate, and I think we're trying to bring the patient perspective for the first time to all these nephrologists on the call. So very appreciative of you sharing the story, your story, and how you kind of came over and continuing to fight the disease that you have, which is amazing. So with that, we'll just have the questions for the panelists. There are a lot of questions in the chat, and please keep adding questions to the chat. I would have first question for Dr. Lafayette here, and a lot of people have this question about hematuria, having blood in the urine along with the proteinuria. What does it mean? Is it associated with risk of progression? Do we look at it? And what do you think about the hematuria in IgA nephropathy, essentially?
Yeah, so I do think the hematuria overall has been proven to associate with more inflammation in the kidney in studies from Japan, China, Italy, and even our own study from CureGN. It does associate with a worse outcome to have persistent hematuria. We now know some of the drugs can help to remit hematuria that benefit the kidney. So I think hematuria is an important factor, but at the same time, it doesn't stand alone in risk scores. We can't independently treat the hematuria compared to proteinuria and other factors. So it's still a little bit of unknown. Again, for patients, I tell them they'd rather not have blood in the urine than have blood in the urine. But by itself, it shouldn't panic anybody. And again, it has to be taken in context with all their other markers of disease.
Great, thank you. I guess and the next question I would probably both for Katie, as well as Dr. Lafayette or Dr. Norouzi, that we have so many options now for treatment. Like Dr. Lafayette, you went over them, and I think a lot of questions comes to how do we choose, what do we choose, and a lot of times I think in these lectures we kind of think about shared decision making, but I think with that patient perspective about Katie, you want to talk, and then either one, Dr. Norouzi or Dr. Lafayette, if you want to talk as to how to have those discussions with the patients as well, because it does get overwhelming for patients to think about all of these treatment options, then thinking about which one to choose, which one is going to help, and the side effects and all the other things, how long to continue, etc. Katie, do you want to, I know Dr. Lafayette has already talked about a lot of these options, and then maybe they can talk, but do you want to take maybe a little bit stab as to how, as a patient, how they process, and what your, with these hearing so many options that there are now, which is amazing for IgA nephropathy treatment options?
I think I cut out there for just a second, so I apologize. No, I have been lucky to have a nephrologist that is very open with communication. He is very good at explaining why he would like to start a medication or why he would like to consider something specific. But he will ultimately allow me time to kind of think about what that would mean for me. You know, I'm a teacher, so immunosuppression for me is kind of at a higher risk. I work in close contact with a lot of kids who are often not healthy and bringing a lot of germs. So that's been something that has been taken into consideration in my sake. But I think it is very heavy to weigh on, these medicines that can affect you, but then come with side effects that you need to be willing to be able to live with. I just actually had this happen just this week. I had some side effects from some medications, and my nephrologist was really fantastic about allowing me to ask all of the questions that I needed and then coming up with a resolution for those side effects, adjusting a medication. But I really think too that something that has helped me is my perspective is taken equally. It is not, I'm the doctor and I think best, so we're going to do this. My opinion is just as important as his opinion. And I think that is incredible, just in building the relationship with the nephrologist and building that trust with my nephrologist. But just knowing that we are coming at this and it is me that has to live with the side effects. And I just think that that's huge, is just that open communication and that trust in deciding what we need to do to move forward.
Great. Thank you, Katie.
Tripsy, I can add something here. I think like having more options is really good because we can individualize the treatment options for patients depending on their background, how active the disease is because of like the lab findings that we have. And the same thing that Katie said, like, they're what they're doing right now, what are the risk factors of suppressing their immune system and everything. Because of where I practice, I have two separate groups of patients. Some group of patients are really educated. They know about the medications. They come in, they want to know more. They want to be part of the decision making. And from my perspective, I have a clinic here that a lot of my patients in that clinic, they just want me to make the decision. And they just say that this is too much for me. And I think like the level of education is really important as well. It can become really overwhelming when you talk to someone about complement inhibitors, the side effects and everything. So I feel like having more options, it's really good, but it's putting a huge responsibility on us as nephrologists as well, because ultimately a lot of patients is like, I don't know. What do you think? And what do you think is going to be the best for me at this point? And they trust us, and that's something that makes me feel like I really want to keep myself updated. I want to hear all the opinions because at the end of the day, I feel like eventually it sounds like I'm making that decision because a lot of options is complicated even for the nephrologists. And most of the times at the end of the conversation, they ask me, what do you think? What's the best option for me?
Yeah, and I'd agree. I think it's really important these days more than ever to have discussions with the patients, to really give them your expertise about what you think will work for them. As I said, you have to step back and really explain what the risks are without beating them over the head with them, and then say how the treatments match their disease in terms of what you think is going on. As Sayna knows, I sort of don't agree with giving the whole kitchen sink to a patient at one time. I want them, if there's not an extreme high risk setting, if they're not losing kidney function visit after visit, I think there's time to trial and error things and then do what the patients will take from you as their best option. And if it works really well for them, there really is not evidence today that says a particular patient must get a complement inhibitor first, or must get steroids, or must get an endothelin antagonist, because the drugs have just been given to sort of general populations and have worked pretty widely, regardless of GFR, proteinuria, or biopsy findings. They've worked somewhat similarly. As I mentioned with the B cell modulators, they may show a slightly better preservation of kidney function, and then we might have to make priorities known, but right now we're not there yet. And so I think having those discussions with your patient, and letting them to really either rely on your expertise entirely or rely on their experiences of what they're more fearful and accepting of, is really important.
Yeah, thank you, Dr. Lafayette. And Sanya. Bonnie, you unmuted yourself. Did you have anything more on this topic from IgA Nephropathy Foundation as a whole, as to how to help patients kind of navigate this current environment of having many options available for treatment of IgA nephropathy, which makes it hard?
Sorry, I'm what happened to my camera. So part of our work is to make sure that everybody understands what's happening to them, and that it's okay to not be okay, to almost justify, like, if you're sad or you're down or whatever, then just go do that. But pick yourself up. We're here to walk you through it. And it's our role as a foundation to give them all this information. So then they'll better able to handle, like, going to their doctors and being mindful and open, because the nephrologist can't understand what they're going through unless they tell them what they're going through. So they need to say, hey, I'm going through this or that, or, feeling a little depressed or whatever. I think it's on both parts. I think it's part of the patient and the nephrologist. So what we do is give them our side and go in and make sure that you're open and have these conversations with your doctor.
Great. Thank you, Bonnie. I guess on the same theme, there are lots of questions in chat about which agent to use. And I know, Dr. Lafayette, you already kind of mentioned it a little bit as to that, but is there specific markers on the biopsy that you look at, or is it if there's no hematuria, do you not go towards any of those immunomodulating therapies, or is there anything, I guess, is what people want to know?
Yeah, Tripti, great. I think that's the most important question. And as I suggested before, I think right now, with the way that the trials have been done, the broad populations that have been treated, and the very limited post hoc analysis that we've seen so far of who responds and who doesn't respond, is I really beg people to stay away from feeling that, hey, if there's 3+ complement on the biopsy, they should get a complement inhibitor. If there's more immune complex, they should get Tarpeo. If it's more advanced disease, they should get a endothelin blocker. Those things make empiric sense, and there's a natural desire to do that. But based on the way the trials were done and the evidence of who's responding so far, I don't believe that's warranted. I think we have to do a whole lot of work at partnering with our patients, with industry, and really getting better granularity about who are responders and not responders. But for the time being, I'm just writing back in the chat right now. I basically think you have to look at your patient and your discussion, as we touched on just before. Also, all those other issues. If the patient's extremely sensitive to steroids, maybe budesonide's not good. If they've got a low blood pressure, maybe then An endothelin blocker may not be best for them. If it's a difficult REMS, maybe you don't want to overcome that. If they can't see their way forward to get vaccines and they're penicillin allergic. So there's more subtle things that may get in the way. And of course, the pre-authorization process may be our biggest undoing. But I don't personally feel, now again, others on this call and definitely other experts feel differently. They feel if you've got a very inflamed kidney, if you have hematuria, that it should direct you. But I could tell you they can't point to any clinical evidence to support that. It's just that empiric sense of, hey, it should be obvious. But again, the results of the studies are not supporting that so far.
Yeah, thank you. I think that's very helpful because I think just reinforcing again and again, nothing specific was in the studies. I guess one of the questions, Katie, I don't know, it is one of those disease which starts in young age and not a lot of symptoms tend to happen with patients with IgA nephropathy. For the most part, I know you struggle with some of the symptoms, but a lot of people don't. And I guess how to reconcile, or one of the trouble, and it was mentioned one of the questions, or one of the troubles we get with patients is how to keep them motivated to stay on the medications, because these are young people in 20 and 30s and feel well, and essentially it's just the lab abnormality. So do you have, or Bonnie, either one of you, if you want to jump in and say how to keep the patients engaged and kind of stay what we call as engaged in the treatment as well?
I think just making sure that your patients are knowledgeable about what the possibility is. It is very hard being on, several medications a day, and I'm young and I feel good most days, but I know what could happen if I don't take my medications, and I think that that's an education that. Yeah, you might feel okay and you are young, but there is this risk out there that if we don't try to address it, you could need a kidney transplant. You could end up in kidney failure. It could, you know, rapidly change at the drop of a hat. And I think that that's just an education of, you know, it is a big deal, even if you feel okay, it is a big deal that you have this, and just trying to reinforce that if left unaddressed, the potential for consequences is real.
Yeah, I don't know, Dr. Norouzi or Dr. Lafayette, do you have any comments on that? How to keep patients engaged and what has
Add
worked?
something, Tripti. I feel like if the patient is not taking the medication, I'm just gonna take the blame on the nephrologist who is starting the medication and not explaining why we are starting the medication. Because if you really feel like patient is gonna benefit from a complement inhibitor, and then you're gonna vaccinate your patient for it, and then you're starting antibiotics, and so it's a huge process, and you're going through the prior authorization. And then patient not taking the medication, it sounds like you were just jumping into starting the medication, not talking to the patient about the options. Because if you're deciding about complement inhibitors, there should be a really extensive conversation about why you think that patient needs this kind of treatment, why you think this is the high-risk patient, you think that they might end up on dialysis, and you really want to prevent complications for them. A lot of our GM patients, when they come to our clinic, they have a lot of symptoms. IgAN patients, a lot of times they are asymptomatic. So I feel like these patients, they take a lot of time. Like my IgAN patients take a lot of time in my clinic because I have to do a lot of education. I don't have to do this much for my lupus patients because they already have symptoms and they want treatment because they feel uncomfortable with their symptoms. But for IgA nephropathy, I'm telling them about the future most of the times and how I want to prevent complications in the future. So I think like a really extensive conversation can help for this kind of issues, like patients going to take the medication, compliance and follow-ups and everything.
I would have to echo that as well. That is something that I've had experience with just in my own personal visits, is the explanation of this is how this medication will help you 10 years from now. So maybe not an immediate, but 10 years down the road, we have evidence that this specific medication will likely do this, and this is how it will help you. And I think that education piece is crucial.
Yeah, and beyond that, I try to, again, not only talk about long-term, but short-term. So I try to really engage my patients in terms of looking at their blood pressure. Hey, are you doing the right thing? Looking at their steps on their phone, just to give them feedback that they're actually doing something and maintaining something that's important, to make sure they look at their empty pill canisters at the end of the month, and that they say, hey, are you going to the pharmacy? And do you like your pharmacist? Is it a good relationship? And then finally looking at their sort of interval urine results, their blood results, saying, hey, you did this. The proteins could have been worse if you're taking your medicines, not taking your medicines, and always try to relate the clinical outcomes over the short term to their use of their medications. Hey, it could have been worse if you weren't taking your medicines, and wink, wink, if you didn't take your medicine, this is maybe why this is happening, right? So I think trying to give them even the short-term follow-up of their blood pressure, their side effects, how's life feeling for you right now? How are you doing free of lightheadedness, dizziness, and then linking those short-term biomarkers of blood in the urine, proteinuria, their kidney function, to what they're actually contributing. So hopefully that helps a little bit.
No, that definitely does. And I think, yeah, Dr. Norouzi and Katie, I think it definitely helps to kind of spend that time to explain to the patients. I know we just have 1 minute left, but I think there were a couple of questions about IgA nephropathy and nephrotic syndrome and minimal change disease. And is it the same disease or is it a different disease? And how do we kind of approach that part? Yeah, Dr. Lafayette.
Yeah, and Trip, you can always answer that. I put it in the text that, again, not everything that has IgA mesangium is IgA nephropathy. We have to work really hard to look at secondary diseases, underlying infections, underlying autoimmune disease that can be directly targeted. And then for that question, again, autopsy studies show that maybe 1 in 20, and depending on your background, 1 in 10 people will have some glomerular mesangial IgA staining in the kidney at all times. So if you do get minimal change disease, FSGS, even membranous, sometimes there'll be some mesangial IgA, and you have to dissociate that and really look at the clinical setting and the rest of the biopsy. And in those cases, we're often just directly treating for minimal change disease.
Sounds good. Thank you. Yeah, and I think that kind of is at 11 a.m. and kind of concludes its seminar, but I really want to thank Bonnie, Schneider, Stuart Miller, and Katie to be here as a part of IgA Nephropathy Foundation, and kind of tell us all what the foundation does. And Katie, thank you for sharing your story, and Bonnie for sharing your family story with us as well. Thank you, Dr. Lafayette, for a great presentation and all the questions, and taking all the questions and explaining kind of the pathogenesis, the current medications. And thank you, Dr. Norouzi, for being part of the panel discussion and all your insights.
And thank you again for this opportunity. We're very grateful.
Okay, well, have
And
a nice
indeed, great to see everybody. Hope to see people in Prague and in Hawaii. I'm sure that's what you're about to say too.
We'll be there.
Yeah. Well, thank you, everybody, and have a nice Sunday.
Thank